So fixed dose combination have been introduced in the guideline, actually in Europe for the management of essential hypertension from stage 1 already, and in the US guidelines it's recommended only if people do not respond to a monotherapy and in stage 1, and eventually initial treatment in stage 2 hypertension, so people with a relatively high blood pressure. But today it's so convenient to use, and we know that we can treat so many patients to target with a fixed dose combination that more and more the fixed dose combination are used for almost any hypertensive patients that need to have a well-controlled blood pressure. And we can use it either as a first-line therapy or as a second-line therapy. We could think that because everything is fixed in the single pill combination, we may actually lose flexibility and maybe less good for personalizing the treatment. But this was true at a time when we had relatively few drug combinations and a few fixed dose combinations. Today, the numbers of fixed dose combinations has increased considerably, and also we have a lot of fixed combinations with different doses, low dose, high dose, and different combinations. So I don't think that today this argument goes against the personalizations. I think we can now adapt to each patient and find a good combination for each patient. A combination that is well tolerated and very effective for each individual. And I think with now what we have on the market is already feasible. The development of the fixed dose combinations is perhaps can be considered as a step towards the polypill. The polypill is a different, in some way a different concept, because here the fixed dose combinations, we want to simplify the treatment for one disease. And the concept of the polypill is to reduce the overall cardiovascular risk of a patient by combining a little bit of different treatment, statins, aspirin, antihypertensive drugs, and different things. So these are two different concepts, but I can agree that the fact that we learn how to use the fixed dose combinations will probably approach us a little bit closer to the use of the polypill and make the polypill more acceptable by patients. You know, there have been some attempts to combine antihypertensive and lipid-lowering drugs. They were not so successful today. So, and it shows that the concept is a bit different, and people are not ready to accept this kind of combination as easy as the fixed dose combination in one disease. So, but it is a step in the right direction towards the multiple therapy in a polypill. I think this is crucial. You know, the treatment of hypertension is silent disease. You have to take your treatment for all your life, and of course, the patient has to be, you know, agreeing with the treatment, and he has to consider that this treatment is important for him. So he has to be empowered to monitor blood pressure at home, to be sure that the treatment is effective. He has to be supported. He has to understand what are the goals of therapy and why he's taking all these drugs. You know, why would you take a drug for all your life if you don't understand why? And what are the benefits, you know? So I think this is absolutely crucial. And if we don't do that, like many patients, many physicians don't do that, the result is that people stop their treatment after a couple of years because they don't understand why they take it, because they don't feel anything. And that's the major issue. They don't feel bad when they are hypertensive until they make complications, and then it's too late. So I think it's very important to empower people from the beginning, make sure that they understand, make sure that they can handle their blood pressure, monitor it, follow it, and take their drugs. This is absolutely crucial. for the long-term success.